For millions of Americans on Medicare, the way people can get some of the most popular weight loss drugs is about to look very different. And if you or someone you know relies on Medicare for prescription coverage, this is one of those changes that's actually worth paying attention to, because the window to take advantage of it is specific. The savings are significant and the details matter a lot. Starting July 1st, 2026, certain GLP-1 medications will be available for a flat $50 a month. That price stays the same no matter what coverage phase you're in or how your plan is structured, at least for as long as the program runs. So whether you're at the beginning of your coverage year or somewhere in the middle, that cost doesn't shift around on you. It's $50. That's it. And for medications that have historically been extremely difficult to afford, that kind of price stability is a pretty big deal. The program itself only lasts 6 months, wrapping up on December 31st, 2026. What happens to pricing and access after that depends on a separate system that isn't fully in place yet. So the start date and end date are firm, the middle is fixed. What comes on the other side of December 31st is still being worked out, and that matters, which we'll get into. To understand why this program exists, it helps to know a little bit about the landscape leading up to it. Back in late 2025, federal health officials rolled out a temporary program to get GLP-1 drugs in front of more Medicare patients. CMS, the Centers for Medicare and Medicaid Services, made the announcement on December 23, 2025, and paired it with a longer-term plan set to kick off in 2027. So the announcement was essentially two things at once. Here's what we're doing right now, and here's where we're trying to go. The short-term piece is what we're talking about today. That temporary program is called the Medicare GLP-1 Bridge, and the name actually tells you a lot about what it's trying to do. It's a bridge, something meant to connect where we are now to where the system is eventually headed. And specifically, it's designed to tackle one of the biggest reasons people can't get these medications consistently. Drugs like Wegovy and Zepbound are in high demand. That's not really up for debate, but the cost and coverage hurdles have made it hard for a lot of people to stay on them long enough to see meaningful results. The Bridge program is a direct response to that problem. Under the Bridge program, Medicare beneficiaries who are enrolled in Part D or a Medicare Advantage drug plan can get eligible medications for a fixed $50 a month. Not $50 after meeting a deductible, not $50 as a starting point that adjusts later in the year, just $50 flat. Every month the program is active. Now, how does that number actually work? The federal government negotiated a supply price of around $245 per month with manufacturers like Eli Lilly and Novo Nordisk. So the drugs aren't being handed over for free. There's a real negotiated cost behind them. The gap between that $245 negotiated rate and the patient's $50 payment gets handled within the program's own financial framework. The patient pays $50. The rest is managed on the back end through the program structure. And when you put that $245 negotiated price next to what these drugs normally cost, the difference becomes even more striking. Typical retail pricing for GLP-1 medications often exceeds $1,000 per month. In some cases, significantly more. So even the government's negotiated price of $245 is a fraction of what someone without coverage might be looking at. And the patient-facing cost of $50 is a fraction of that. For people paying out of pocket or dealing with inconsistent insurance coverage, that difference doesn't just make treatment cheaper, it can determine whether treatment is even an option at all. Now, here's something important about how the program actually operates, because this is where it gets a little different from what most Medicare patients are used to. The program runs on a separate track from standard Medicare Part D. It's not plugged into the usual billing and reimbursement system. Instead, pharmacies collect the $50 from patients at point of sale, and then they get reimbursed through a centralized process that runs independently from the standard Medicare system. That structure is what makes the fixed $50 price possible across the board, but it also creates a consequence that patients really need to understand going in. Because the program operates outside the standard Part D structure, those $50 monthly payments do not count towards your deductible or your true out-of-pocket spending threshold. That's not a small detail. In the standard Medicare system, what you pay accumulates over time and eventually moves you into different coverage phases with different cost structures. Under this bridge program, that accumulation doesn't happen. You could pay $50 every single month from July through December and enter January with zero progress towards those standard thresholds. That's just how the program is built. So what medications are actually covered? The list includes all formulations of Wegovy, the quick pen version of Zepbound, and Foundayo, which was added to the covered medications list in April 2026. That said, coverage isn't automatic and it isn't universal. Prior authorization and clinical criteria still apply. Not every formulation of every drug makes the list. So while the price is fixed for those who qualify, getting to that point still requires going through an approval process. The $50 is available, but it has to be unlocked through the standard eligibility pathway first. When the program launches on July 1st, it will happen across all 50 states and U.S. territories. That's a nationwide rollout, not a regional pilot or a limited test. Medicare beneficiaries with drug coverage, including those in Medicare Advantage plans, may be eligible. Dual eligible individuals, meaning those who qualify for both Medicare and Medicaid, are also included in the program. So the reach here is genuinely broad. It is designed to be accessible across different types of Medicare coverage structures, which means a wide range of patients could potentially benefit. But broad availability doesn't mean everyone gets in automatically. Even with a nationwide framework, eligibility requirements still set limits on who can participate. Approval determines access, so the program can be available everywhere and still not apply to every individual who wants it. That's an important distinction, especially for patients who might assume that nationwide availability means they're automatically covered. The timeline is really one of the most important parts of this whole program, and it's really worth sitting with it for a moment. The program opens on July 1st, 2026. It closes on December 31st, 2026. That's a 6-month window. During that stretch, patients who qualify can start treatment under a fixed, predictable cost structure. There's no guessing what the bill will look like month to month. It's $50 in July, it's $50 in October, it's $50 in December. And then on July 1st, 2027, that pricing structure is gone and something different takes its place. That something different is called the balance model, and it's the longer-term system that the Bridge program is designed to lead into. Starting January 1st, 2027, the balance model is expected to integrate GLP-1 drugs into standard Medicare Part D coverage. In many cases, the $50 monthly cap is expected to continue under that system as well. But, and this is a meaningful but, whether that $50 carries over depends on which plans participate and which manufacturers sign on. It's not guaranteed to work the same way for every patient who was in the Bridge program. So when you look at the full picture, the structure is a deliberate sequence. A temporary lower price brings more people in during the program period. It reduces the cost barrier that has kept a lot of Medicare patients from accessing these medications consistently. That access window is 6 months long. And then what comes after it has its own set of conditions and variables that aren't fully locked in yet. That transition point is worth thinking about carefully, especially for patients who start treatment during the 6-month window. If you begin a GLP-1 medication in July or August under the Bridge program, you could be several months into treatment by the time December rolls around. You may be seeing results. You may be adjusted to the medication, and then the program ends and the coverage structure you've been relying on changes. Because the payments made during the Bridge program don't count toward standard out-of-pocket thresholds, you won't have built up any progress in the standard Part D system when that transition happens. You're essentially starting fresh from a cost accumulation standpoint, even if you've been paying every month. And beyond just the cost side, the program itself introduces a fundamentally different way of paying for these medications. Rather than running through normal insurance billing, where your payments stack up, your deductible gets chipped away, and you move through the coverage phases, the Bridge program uses a parallel reimbursement structure with its own rules and its own back-end process. That's what makes the flat $50 possible. But it also means the program exists somewhat outside the normal rhythm of how Medicare coverage works. It's a separate lane with a defined on-ramp and defined off-ramp. Looking at the full arc of what this program does, the shape of it is fairly clear. Costs come down, access expands. Then there's a hard stop. And the continuation of that access depends on how the next phase gets implemented. The Bridge program improves things during its window. Whether that improvement holds over the long run is a question that won't have a full answer until the balance model is actually up and running. For now, the program is confirmed and on schedule to begin in July 2026. Additional implementation details have been released as the launch has gotten closer, including updates on the list of covered drugs, which is how Foundayo ended up being added in April 2026. But the core structure of the program hasn't changed from what was announced in December 2025. 6 months, a fixed monthly cost, available everywhere, and a planned transition into a longer-term model that is still being finalized. For patients, the most immediate impact is a lower price tag and a clearer path to actually getting started on treatment. If cost has been the barrier, and for a lot of people on Medicare it has been, this program directly addresses that, at least temporarily. What happens after the program ends comes down to how the balance model gets put into practice and whether the conditions for continued affordable access actually come together the way they're expected to. Right now, access is growing. The cost is temporarily manageable. And long-term stability is still an open question, one that a lot of Medicare patients will be watching very closely as December 31st, 2026 gets closer. If you want to stay on top of how pricing, coverage, and access to these drugs keep evolving, subscribe to Dose and Demand. And if this program were available to you, would $50 a month be enough to start treatment, knowing that the cost could change once the 6 months are up?